Good morning, good afternoon, good evening, good night, although I don't really want you to doze off, so stay awake for a little while longer. Wherever you are listening to the webinar from, whatever time of day it is for you, whatever time of year, whatever season, you are very welcome. What a pleasure to have you come and join this webinar, which I hope is going to be really helpful to you. I'm going to do a little bit of clinical thinking, a bit of pathogenesis, and then bring the whole thing together to really optimize the way in which we look after people with psoriatic arthritis. So, first of all, who are we? Well, first of all, I'm the most IT incompetent chair in the rheumatology world, which is why slides will fly around every now and then. But let me introduce who we are. Well, first of all, my name's Iain McInnes. I'm a rheumatologist based in the University of Glasgow in sunny Scotland in the UK. We're going to be joined electronically by Professor Laura Coates, who is working in the University of Oxford, and by Professor Christopher Ritchlin, who works in the Centre for Musculoskeletal Research, Allergy, Immunology, Rheumatology Division, University of Rochester in New York in the United States. And of course, Professor Philip Mease, Director of the Rheumatology Research, Providence Swedish Medical Center, Clinical Professor, University of Washington, Seattle, Washington, USA. I have to say, just as an aside, Professor Mease was gracious enough to entertain many of us for the GRAPPA meeting this summer in Washington. Don't believe any of the nonsense that he may occasionally tell you about the rainy, damp climate. Beautiful. We didn't see a cloud in the entire time that the GRAPPA community went to the beautiful state of Washington. So I highly commend Philip, of course, but also his very beautiful homeland. So welcome to my fellow faculty. A couple of quick notes on housekeeping. If you're an attendee, and you are, if you're here, you will be on mute for the duration of the meeting. However, please do ask questions. You can type them into the Q&A function, which you'll find online if you look down at the bottom of the screen or the side of the screen, depending on how you've got your desktop configured. Please do ask questions at any time. So when we say something interesting, provocative, or new, please, if that question comes to you, get it in there and we will be able to deal with that at the appropriate Q&A session. And if you have any technical difficulties, use the chat box, and one of the extraordinary gurus, these IT masters in the background, will come to your assistance. Okay, well, what are we talking about today? Well, we're talking about management of psoriatic disease, a spectrum of clinical disorders, and that's something that Laura is going to take us through in considerable detail in her inimitable style and fashion, thinking about the different clinical areas, the tissues involved, and the kinds of strategies that might impart in terms of our therapeutics. We're then going to think a little bit about underlying pathology. Those of you who have come to know me and my fellow faculty over the years will know that we firmly believe we're in the era of pathogenesis-driven therapeutics in rheumatic musculoskeletal diseases. And no one better than Christopher Ritchlin to take us through the kinds of similarities, differences, and of course, by inference, the clinical consequences of pathogenetic subtlety. And then finally, it's going to be a real pleasure to have Philip take us through some of the potential clinical opportunities that arise. And our focus today is on the IL-23 targeting pathway, and we're going to use gazelkumab by and large as our exemplar for that, although and Philip will make it clear the principles are probably similar across the different modes of action available to us. And we're going to think just a little bit about how these different approaches have both similarities and potential subtle distinctions. And then, of course, we'll join together for a Q&A session. So we're going to start with a presentation from Laura. Laura, unfortunately, is unavailable for this first part of our webinar. She has graciously agreed to record her session. So you're going to hear the first piece, which is Laura giving her recorded presentation, and then we'll move through the additional presentations from Christopher and from Philip, and then of course we'll all come together, and all being well, Laura is going to join us for the live Q&A. So without further ado, I'm going to hand over to recorded version of Laura, which will, I'm sure, be every bit as wonderful to listen to as live version of Laura, which we'll come to a little later on. So Laura, over to you.
Thank you. So I'm going to start off by talking about the burden of psoriasis and psoriatic arthritis across different domains and considering how these conditions impact on our patients. These are my disclosures. So we know that patients with psoriatic arthritis and psoriasis have a really very multifaceted disease, and sometimes some of the associated conditions and additional domains that are involved are not that obvious. So what seems on the surface to be a relatively simple kind of joint and skin focused disease actually has an awful lot more going on if you speak to the patients and ask a bit more about the different domains of psoriatic arthritis, the related conditions, and the comorbidities. And we all know as clinicians and as rheumatologists that PsA is a very heterogeneous disease. So we see involvement in these 6 key GRAPPA domains, but then that kind of combines in different patients to give a very different phenotype. You might have a patient with arthritis and dactylitis, or somebody with axial disease and skin disease, and the way you manage those patients is going to be very different. And we know that the impact of disease is significant really across these different phenotypes. So this is data looking at the PsA impact of disease score. This is a really nice questionnaire developed by EULAR and co-developed with patients to really consider how the disease impacts on them and what's important to them. And you can see here, roughly in kind of rank of importance, are the different elements that patients said really impacted on them from the disease. And you can see in a cross-sectional study, this is a large cross-sectional study across Europe, that we see quite high scores, nearly or over 4, pushing on to half of the way up the ranking scale from 0 to 10. These patients are struggling with pain, with skin symptoms, fatigue, and the impact that this has on patients' lives day to day. And we know that we see things quite differently, really, between the rheumatologist and the patient. We have a very different perspective on the same disease. And this is a really nice study done a few years ago in Canada, where they looked at the global score. So we often measure a patient global or a physician global. And then they looked statistically to see what seemed to be driving that score in a big cohort of patients with psoriatic arthritis. So if you look at the patient global, how patients overall score that they are doing, you can see that what drives that is predominantly things like pain, fatigue, and quality of life. So they're thinking much more about the impact of the disease. If we look at the physician global and what's driving our scores, that's predominantly around the objective measures that we often use in clinic. So joint counts, dactylitis, a little bit of pain and quality of life as well. So although we both see this significant impact, actually how we perceive the disease is quite different in the clinic. And that's similar with psoriasis. So again, from the patient point of view, you see pain and quality of life being the big drivers for the psoriasis score. From the physician point of view, it's much more the PASI. It's what we can see and what we can measure in terms of the impact of the disease that we kind of rank as a global score. So generally speaking, I think when clinicians are assessing disease, we're thinking about activity, what we can see, what we can feel, what we can touch. And the patients are thinking about how this makes me feel, how much pain I'm in, how it impacts on my quality of life. And obviously, I mentioned that heterogeneity at the beginning. This is some really nice data from the Netherlands, looking at whether pattern of disease matters. We've kind of considered psoriatic arthritis as polyarthritis, 5 or more joints, oligoarthritis, less than that, or monoarthritis, just 1 joint involved. And I think there's generally an idea that the patients with mono or oligoarthritis have milder disease. They have less joints involved. They're not going to score, for example, as highly on something like a DAPSA score. But actually, if you look at the impact of the disease here, and this is looking at quality of life, you can see really regardless of the pattern of disease, you still see a significant impact on somebody's quality of life. So it may only be one or a few joints, but it's still impacting on patients just as much as it is if you have many joints involved. If you look at enthesitis, you can see the minute you have enthesitis, you get poorer quality of life, so having that additional domain involved. And then on the right-hand side of this slide is looking at back pain, and this is looking at any back pain, but then also specifically at inflammatory back pain in that lighter kind of green colour. And you can see here that what matters particularly is having back pain in general. That has an impact on people's quality of life, but maybe a little bit more even for some of the things if that's an inflammatory type of back pain. So living with involvement in different domains of the disease, in addition to kind of the standard arthritis and skin disease, puts additional burden onto our patients. And the axial disease thing is tricky. Axial psoriatic arthritis presents often quite differently to axial spondyloarthritis in general. So the AS or AxSpA patients we think of as being very often B27 positive, having a higher rate of uveitis, and being much more axial predominant. So the main symptoms coming from the back. Whereas patients that we classify with axial PsA are much more likely to have peripheral disease, to have dactylitis. They're often a lot older in our PsA cohorts, and obviously much more likely to have psoriasis as well. But it's very much a spectrum, and I'm sure the clinicians in the audience will recognise this in their clinic. There are some patients who have very typical AxSpA ankylosing spondylitis, but maybe have psoriasis or a family history. And then there are patients who have much more predominant peripheral disease as well as a bit of axial disease. And I think there's a spectrum of all sorts of cases in the middle. So taking into account that axial disease is important for our patients as well. And then obviously we mentioned skin. This is probably the commonest extra-articular domain that we think about as rheumatologists. And this is a really nice study looking at quality of life in the different colours by how much your joints improve using the DAPSA score along the bottom, and how much your skin improves using the PASI going vertically up this graph. And what you can see is that the patients in this PsA study probably link their quality of life more to their joint disease. That's more of the problem for them. But if you want to get a really good outcome, to get to the red, where you're seeing the biggest improvement in quality of life, you need to improve both. You need to show an improvement in DAPSA and in PASI, in joints and in skin, to get people feeling well. So the skin very much matters to the patients we're caring for as well. And then beyond the skin, the joints, the axial disease, we also have a lot of comorbidities that are relevant in psoriatic disease, and they have a big impact on patients' quality of life, on how the disease affects them day to day. And that often also interacts with our therapy choices, either because we're picking a drug to try and help a comorbidity like IBD, or we're picking or avoiding a drug, even thinking about different comorbidities like liver disease. So the related conditions like IBD and uveitis are obviously a significant issue for all patients with spondyloarthritis. And here you can see the chance of developing IBD or uveitis is significantly raised in patients who have psoriasis and psoriatic arthritis. So we often see that overlap in that kind of family of spondyloarthritis conditions. But beyond the kind of spondyloarthritis typical features, we see a lot of other related comorbidities. Perhaps unsurprisingly, for people who've been living with a chronic skin disease, often for many years, and then a chronic musculoskeletal disease as well, we see quite a high rate of anxiety and depression. And that's even higher in those who have psoriatic arthritis compared to those who have psoriasis alone. And on the right-hand side, you can see an increased risk, even of suicide risk, in patients who have inflammatory arthritis. this case rheumatoid and psoriatic arthritis, and that's potentially even higher in the psoriatic arthritis patients. So that's a big issue that will impact on our patients' lives, obviously, in terms of their quality of life, but also links in very directly to their treatment in terms of their engagement with medication, their adherence to treatment as we look after those patients. And then I think really typically in psoriatic arthritis, we see a lot of issues related to the metabolic syndrome. This is something that we should, as rheumatologists, be aware of when we're caring for these patients. Obviously, cardiovascular risk is also something we think about in other conditions like rheumatoid. But there's a very high rate of involvement of the metabolic syndrome in patients with PsA. So these are the 5 elements of the metabolic syndrome. So blood pressure, cholesterol, obesity, high glucose, diabetes, and a low HDL. And when people have looked in psoriatic arthritis cohorts, this is data from Ireland, you can see increased rates of the different components of the metabolic syndrome, particularly with hypertension and obesity being the most common. And often these things cluster together. So on the right-hand side, you can see there are about 20% of patients who just have one element of the metabolic syndrome, but a lot of patients have 2, 3, or even 4 of the different components in that same patient. And we know, obviously, that that's linked to their later cardiovascular risk. So we see that in the data as well. So in psoriasis and psoriatic arthritis, we see an increased risk of MI on the left-hand side, or kind of all cardiovascular events shown here on the right-hand side. And it seems to be linked to severity of disease as well. So you can see here that severe psoriasis has a much higher risk of those with mild psoriasis. And then they've tried to look more at psoriasis versus psoriatic arthritis here, showing an increased risk of cardiovascular events. And there's some ideas about whether we might be able to influence that as well. I think we have a clear role to play in terms of thinking about the metabolic syndrome, thinking about blood pressure, making sure that patients are getting the kind of holistic medical care that they need from GPs or primary care physicians. But also we suspect that if we control their disease well in rheumatology and manage to get rid of active inflammation, that may have a benefit. So this is data from Hong Kong, looking at patients who had treat to target therapy, so aiming to get people into remission or low disease activity. About half of them did achieve low disease activity over that period. And for those that were in sustained low disease activity or minimal disease activity, you can see that this appears to have a protective effect. You've got a reduction in IMT, in plaque area, using ultrasound to look at markers of cardiovascular risk. We know for sure, and with a lot of our therapies, that obesity has an impact on therapy response as well. And this is one of those most common items that we saw in the metabolic syndrome in our PsA patients. So the odds of achieving good outcomes in kind of routine clinical practice, so with standard care therapies, are much lower in those who are overweight and obese. And it seems to be kind of a dose-dependent relationship. So the more overweight patients are, the less likely they are to do well and to achieve MDA. But there is something we can do. So looking at weight loss does improve outcome, and a relatively small weight loss of 5 to 10% of body weight, even in patients who remain overweight at the end of that. So you might go from obese to less obese, that still has a positive benefit. So even if they still are quite significantly overweight, that reduction makes a difference. There have been some studies looking at this, this one with quite a significant intervention. So this study took patients who had psoriatic arthritis and a BMI of over 33, so they're in the obese category. And they were supported by dietitians, but they were treated with essentially a liquid diet replacement, like a kind of diet shakes, which dropped their intake to 640 calories per day, which is obviously very low calorie diet, for 12 to 16 weeks, depending on their weight. And then they went on to kind of a normal food diet, but energy restricted for 18 weeks beyond that. And they kept their psoriatic arthritis treatment stable, so they were on the same DMARDs. But over the course of that study, you can see it did drop their BMI. They've come down on average to below that obese category, and nearly doubled the chance of patients achieving minimal disease activity. And a lot of that is driven by patient-reported outcomes, so less pain, less fatigue, but also lower levels of tender joint counts, enthesitis, body surface area, and CRP. So there does seem to be a very significant benefit if you can support patients to lose weight. And obviously linked to weight is also the liver disease that we see in patients with psoriasis and psoriatic arthritis. This is probably one of the things that we grapple with a lot day to day in our patients receiving conventional DMARDs and having abnormal liver tests. So this is a significant issue across psoriasis and psoriatic arthritis. And is linked to other comorbidities as well. So unsurprisingly links in with obesity, with diabetes and hypertension, and kind of that metabolic syndrome pattern. So all of these issues with comorbidities, as I alluded to, link into our treatment. So when we're choosing therapies in psoriatic arthritis, obviously we're tailoring it to the patient. Do they have axial disease? Do they have severe skin disease or very impactful skin disease? But we're also thinking about related conditions and comorbidities. Can we treat two conditions with one drug? For example, if somebody has Crohn's disease or ulcerative colitis, can we use a drug that's licensed for both psoriatic arthritis and IBD? Or in some cases, are there drugs that we should avoid? So with liver disease, bringing in cautions around methotrexate, for example. So this is something that's very relevant to us day to day, thinking about the comorbidities as well as the main disease. And I just wanted to mention towards the end this idea around difficult to treat arthritis, which has become a very hot topic at the moment. This is data from the GRAPPA survey looking at difficult to treat disease. And it's been decided based on feedback from clinicians that we should separate out a difficult to treat kind of phenotype of disease where patients are non-responsive to immunotherapy, maybe have tried multiple drugs and failed multiple drugs, and you know that they have active inflammation in the tendons, in the joints, in the axial skeleton. And then those who are complex to manage patients, which brings in all the other elements of disease. So the comorbidities, the depression, the anxiety, concomitant fibromyalgia, those kinds of issues, which is particularly relevant, I think, to those complex to manage patients. But with difficult to treat disease, we're talking about patients who failed multiple therapies. The most likely definition it looks like will be patients who failed one conventional drug and two targeted drugs. So the impact of disease is high, but also we have a significant proportion of patients who we're struggling to treat, struggling to manage well. And so it's really important that we look to having more therapeutic options in the future. So to finish up, the burden of psoriatic disease is significant. It varies between patients, but it's quite broad in terms of how it impacts on them, both directly with things like pain from arthritis, but also quality of life and broad impacts on kind of people's day-to-day normal activities. That relates to different domains of their psoriatic arthritis. Doesn't seem to be particularly related to the number of joints. So oligoarthritis still has a big impact. But I think the number of domains, so the involvement of skin, of entheses, of axial disease, all builds into that higher impact of disease. It's definitely linked to comorbidities, which are a big issue for our patients in terms of their quality of life, their chance of achieving good outcomes on rheumatological therapy, and also obviously on us in terms of the drugs that we can use. And I think we all do this as clinicians, but it's key that we can personalize therapy based on that heterogeneity of disease. So the domains of disease that are involved, the related conditions and the comorbidities help us to select, hopefully, the right drug for the right patient at the right time. And that's what we've got to do as clinicians working with patients, to understand what's impacting them, where the disease activity is coming from, and try and select the best therapy to address those issues, thinking about controlling inflammation with biologic therapies, targeted synthetic therapies, but also about careful management of the comorbidities and the other issues. And that's going to be liaising with other specialists and thinking about broader management of the patient as a whole. Thank you very much.
Laura, thank you so much. As ever, crystal clear and so incredibly practical, pragmatic, and actionable for all of our clinics tomorrow morning or tomorrow afternoon. Well, what we're going to do now is move on and listen to Professor Christopher Ritchlin, who's going to think a little bit at starting in the clinic, as always, but just take us through some of the key elements of pathology, pathogenesis that can inform therapies. Christopher, you are the master of the topic, and I'm really looking forward to hearing what you have to say. Over to you, sir.
Thank you, Iain. It's a pleasure to talk on this important topic, and really an even greater pleasure to follow Laura's marvelous clinical introduction and defining the complexity and heterogeneity of psoriasis and psoriatic arthritis. So next slide. So these are my disclosures. And what I want to talk about, get this going here for you, is talk about team care in psoriatic arthritis, which I'll start off with, and cellular and molecular heterogeneity in this disease. Briefly about the key mechanisms and pathways of psoriatic arthritis and the cellular action of IL-17 inhibitors and IL-23 inhibitors, with additional details about IL-23 inhibitors. So really, in talking about the complexity, it takes a village to manage psoriasis and psoriatic arthritis patients. This is our combined clinic. I'm sitting there on the left pontificating. There's a patient with her back to us, and over on the right is a dermatologist who specializes in psoriasis. Next to him is a psychiatrist who works with our patients, and then we have a rheumatology fellow and a derm resident. So we basically have these clinics together where we're able to work with the patients and address their problems from the skin, the joints, and obviously the psyche. And we found that this is really an effective strategy, which I'm sure, and I know many centers across the world are also embarked upon. So just emphasizing the challenges that we face is this study, and there have been many like these, looking at long-term persistence of second-line biologics in PsA patients who've been priorly exposed to an anti-TNF agent. And you can see it's a rather large population, almost 3,000 patients. And these are patients that have had an inadequate response to an anti-TNF and have been changed to either an IL-12/23 inhibitory agent, an IL-17 inhibitor, or a TNF inhibitor, and looking at persistence over 3 years. And what's really shocking here is in the individuals who are TNF inadequate responders, persistent rates at 1 year are 42%, and at 3 years are 17% for the agent that they were switched to. And compared to psoriasis, where the persistence rate in the same population was about 41% at 3 years. So why is this happening? What is it about psoriatic arthritis that makes this persistence so challenging? Well, I think that it has to do, as already mentioned by Laura, of the great heterogeneity and the complexity of this disease. She beautifully outlined the domains of the disease, which we all deal with in the office, but we are, like our pulmonary colleagues, are trying to understand phenotypes of these particular domains and the underlying endotypes or biologic mechanisms. And this slide, which we recently prepared for a grant, just shows you the associations that we have with the various domains, and then the cell populations which are also seen in these various tissues. We really need to understand in much greater depth what these endotypes are. In other words, the biologic mechanisms that are present in each of these different domains, because we suspect that there's some very important differences which we can utilize when we're outlining therapy for a patient with multiple different domain involvement. So this multi-tissue involvement is also shown pictorially in this following slide. So yes, we see TNF alpha, we see IL-23, IL-17 in the skin, the joints, and the entheses. But in each of these particular tissues, certain cytokines or cytokine pathways or cellular elements dominate. So in the case of the skin, we know that IL-23 is a major driver of this disease and probably of greater central importance to the pathophysiology than TNF and probably IL-17 above that, but below 23. In the joints, it looks like TNF is a very major driver, especially of the destructive joint disease, whereas IL-23 and 17 are there, but may not have that as strong an effect. In the entheses, as I'll show you shortly, there's very strong data suggesting a dominance of an IL-23 mediated pathways along with the generation of prostaglandin E2. Now, these are where we sit now in terms of our understanding of what's happening in individual domains, but we have much to learn. So this is a mechanistic model of psoriatic arthritis. I like the way that this has been put together. And basically on the outer circle, you're looking at major inducers, which include mechanoinflammation through the activation work by Iain and others of tenocytes and the generation I've already mentioned of PGE2 and then pain, subsequent pain. We know from Laura's great talk of the important contribution of metabolism and obesity and driving inflammation through a variety of mechanisms, including free fatty acids, as well as dysbiosis and the generation of inflammatory cytokines by adipocytes and their neighboring macrophages. Of course, psoriatic skin inflammation is an example of tremendous activation of a number of different pathways, both in the dermis and in the epidermis, through the release of a variety of important cytokines, including IL-23, IL-1, IL-17, and TNF. And then the last one, of course, is a really central role, and I'll talk to this a little bit in a moment, of intestinal dysbiosis, which is where it may all begin, and there's accumulating evidence that that is the case, where you have a disruption of barrier function, activation of a variety of immune cells, both innate and acquired, as well as release of various antibodies such as IgA, which can generate subsequent downstream pathways. And these are the enhancers, and they include, of course, IL-17 released by innate and acquired cells, and it can drive the inflammation in so many different tissues and cells, as we'll outline in a moment. And then down to the effectors. These are the innate effectors predominantly. We see TNF and neutrophils and macrophages, which are releasing TNF, which synergizes with IL-17 to drive so many of the inflammatory and bone destructive effects that we see in this disease. So the real challenge we face as clinicians is that outcome measures don't reflect phenotypic heterogeneity. Again, this is from Ian's group. I think is a marvelous paper that outlines the challenges and a way forward. So the idea behind this is that distinct pathologic mechanisms may explain tissue-specific response to different therapies. So again, getting back to Laura's personalized therapy. While individual tissue environments produce specific signatures or biomarkers that have to be approached in an individual patient in a distinct and complementary manner. And then again, leading us to this third bullet, a precision-based approach, which we've been hearing about for so many years in so many different diseases, many of them in rheumatology. But I really think that we're on the threshold of achieving that type of approach as we learn more about those endotypes that are linked to the individual domains. So let's talk about briefly some of the key signaling pathways that are driving the disease in these various domains. And the first one, of course, is one that's been around for a very long time. And really, we had the first therapy due to Phil Mease's great phase 2 study with etanercept, and then move forward with all the four other anti-TNFs that we now have approved for psoriatic arthritis. I'm focusing on TNF-R1. You also know there's TNF-R2, but R1 is really key for the pathogenic pathogenic events that occur driving TNF production in the joint and skin. And it's a complicated pathway as shown here. So you have the TNF receptor, a trimer, which is bound by TNF, and it can drive a couple of downstream events, which is dependent upon the cell state, cell-cell interactions, what's happening in terms of the oxygen tension in the tissue. And the most common cascade that we're familiar with is moving to the right. So you have activation of TRAP and MAP kinase, and then downstream activation of NF-kappa B and Jun, which drive the production of inflammatory mediators and survival proteins. On the other hand, in certain situations really determined by the environment and cell-cell interactions that I previously mentioned, you can have the release of caspase-8, which then generates all of these effector downstream caspases, which result in cell death. So depending on these different variables, the cell will either move toward generating inflammation through inflammatory mediator release, TNF, or actually the death of the cell. Well, what about IL-23 and IL-17 cytokine pathways? Well, these are also somewhat complex, although in a different way. So if you take a look at a Th17 cell, which has been activated by IL-23 and activates the ROR gamma T transcription factor, you have generation of a number of cytokines, including IL-17, IL-22, also can be seen as gamma interferon and GM-CSF. So this cell then can release, I'm showing only two of them here, IL-17A and F, IL-22, which bind to their specific receptors as shown on the right and can drive keratinocyte proliferation, osteoclast generation, and additional inflammatory events. On the other hand, looking down below, direct production of IL-23 by a dendritic cell or a macrophage can bind to the IL-23 receptor, P19, P40, subunits is shown here, and drive inflammatory events as well, showing here as fibro-like synoviocytes and a variety of downstream inventions, all coming through IL-23 generated through Th17 cells or the release of IL-23 directly by a monocyte or a dendritic cell, and possibly even a keratinocyte. Important to understand that distinction. So there are a variety of cells that produce IL-17. It's an incredibly pleiotropic cytokine that can have both homeostatic and pathogenic functions. And you can see here it can be released by acquired immune cells, which include CD4 and CD8, a variety of innate immune cells shown below here. And so it is very much regulated at multiple different levels in both the acquired and innate immune system. So we also know, as I mentioned, that you have to think of the Th17 cells as either homeostatic or pathogenic in a very simple way because they're quite different. So here you see the protective immunity generated through IL-17 release, the usual kind of immune synapse you're used to seeing, the release of IL-17A and IL-22 shown here, and then generating an immune response to fungi and bacteria shown on the right through chemokines and attracting neutrophils and then activating macrophages. So this is really important for protective immunity. On the other hand, in the setting of an infection shown below, the immunologic synapse is exactly the same as I showed before, but downstream events are different because now you have the release of other additional inflammatory cytokines, TNF, as well as GM-CSF, gamma interferon, which then drive the release of a variety of other mediators like metalloproteinases, IL-6, etc. And they can then really go after cells that have become, they can go after intracellular processes that are generated by inflammation or by some kind of pathogen. So here you have the two faces, if you will, of the IL-17 response. So there are also, just like there's a number of cells that can release IL-17, really a great a variety of cells can respond. And you can see here, as shown in this slide, that these cells range from myocytes to adipocytes, fibroblasts, neurons even. So there's even a role of IL-17 in neuronal signaling. And of course, of great importance is the gut epithelial cell, which I'll outline more clearly in a moment. So we also know that IL-17A is just not one molecule. IL-17 is not the whole story. So there's a family of isoforms, IL-17A through IL-17F, who have 50 to 60% structural homology. It turns out that IL-17A is more potent and has broader biologic effects, but IL-17F is more abundant in the circulation. In addition, IL-17A has stronger affinity for the IL-17RA-RC receptor, but both of these isoforms can synergize very strongly with TNF. And there's data now that you're very well aware of, and that is that now a drug called bimekizumab, which has now been approved in both Europe, the UK, and the United States for psoriasis and PsA, that dual neutralization of IL-17 and F provides greater suppression of inflammation than IL-17 alone. And there's both in vitro data for this and also some data in clinical trials, particularly in psoriasis. So the IL-23 signaling and downstream effectors, you know that IL-23 is made up of two subunits, P19 and P40, in contrast to IL-12, which is shares the P40 subunit but has P35. And I'm focusing on the downstream signaling of IL-23, which is through TYK2 and STAT3, and then drives a phosphorylation of STAT3 that then can generate downstream events in the release of the cytokines shown in the lower left-hand corner. So above in the right-hand corner, dendritic cells, macrophages, through the release of IL-23, which really drives the development of a pathogenic Th17 cell, not one that's homeostatic, can act on a number of different cells, including innate immune cells, shown here as T gamma delta cells, NKT cells, and ILC3, to release all of the cytokines shown in the bottom of the slide, and also for the Th17 cell as well, which now becomes pathogenic with that IL-23 engagement of its receptor. So how do we think about IL-23 signaling in the intestine, intestinal mucosa, the skin, and the joints? Well, in the intestinal mucosa, Th17 cells are present and they're homeostatic. They're there to maintain barrier function, to basically make sure these cells produce mucus, and that they can produce antibacterial peptides to really prevent a dysbiotic response. They can also generate the release of IgA antibody from B cells. And so these cells are critical to our health. And so it's when we have dysbiosis, however, what can happen is these Th17 cells, which express SLAM6, which is the homeostatic cell, if you will, then actually can become activated by IL-23 to express CXCR6. And then that cell is now pathogenic and can migrate from the gut to the particular tissue from which the autoantigen arose. And so this is a key difference in terms of, again, thinking of that pathogenic versus non-pathogenic Th17 cell, and the gut maybe it looks like is the origin of this very important immune response. Whereas if you look at the skin, we know very well that in the dermis, there's a generation of IL-23 from the dendritic cells and macrophages, subsequent release of IL-17 and TNF, and that this drives the hyperproliferation of keratinocytes, also with the release of IL-22 and also TNF. In the lower area of the joints, as mentioned earlier, IL-23 is very important, particularly in enthesitis, at driving the production of IL-17, 22, and TNF from both innate immune cells as well as acquired immune cells. And in the case of axial SpA, it may be generating IL-23 through axial misfolding or mechanical stress, or from danger signals being presented in the gut, and also resulting in release of PEG2, which is very important in enthesitis. So I want to just talk briefly here about T-resident memory cells in humans. These are T cells which are resident to the tissue. They express CD69, and a subset expresses CD103. They provide rapid on-site response and reactivation in the skin, the joints, the lungs. And the highest number of these cells are at the sites of primary activation. They're long-lived. Whether or not they recirculate is a certain very active area of investigation. It turns out that they can recirculate, but for now, we're going to really focus on their roles in the tissue itself. So they're antigen specific, and you can see that in the skin, the gut, and the lung, they're really programmed to respond to specific pathogens. So what's really interesting is there's some preliminary data from a couple of studies. I'll show you one, whereas treatment with anti-IL-23 agents can result in improvement in the skin phenotype of psoriasis, which is accompanied by a decrease in the number of T-resident memory cells in the skin. And it's shown here comparing a study with guselkumab and secukinumab. This is from the larger ECLIPSE study, and they're looking to see over a period of 24 weeks whether or not there's a decline in the T-resident memory cells in the skin. And they're showing here that you do see this with IL-23, but not IL-17 blockade on the left. And then when you look on the right, they're actually looking to see whether there's a change in the T regulatory cell population. And you see it's maintained with IL-23 blockade, but it appears not to be the case with secukinumab. There's a second study shown down below that's highlighted by Wu, published in Scientific Immunology, that used risankizumab, and they looked at patients who had complete response to risankizumab with psoriasis in the skin lesions, and those patients with the strongest response had a marked decline in their T-resident memory cell population, whereas those patients that did not have a strong response, those T-resident memory cells persisted. So this may be a key to long-term responses to an agent, possibly even off therapy, but further studies need to be performed to support this hypothesis. This is just showing you that CD8 cells express T-resident markers in PsA synovium. This is from my group, and this is showing you CD8 cells that are in green. CD103 and CD69 are two T-resident cell markers shown in white and red, and then this is a DAPI, a nuclear stain, and showing you clearly that these cells are present in pretty large numbers in psoriatic synovium. So I want to end with this very interesting finding that guselkumab is a monoclonal antibody to IL-23 that has a very unique function in the sense that it can bind to the CD64 FcR gamma 1 receptor on CD14 cells. And as you can see here, the guselkumab, through a structural elements in its Fc domain, can bind to the Fc receptor on the CD14 cell. And of course, this is the same cell that is producing IL-23. And the notion here is that the cell is the antibodies right next to or attached to or near those other monocytes that are producing IL-23 and can bind to the IL-23 and therefore inactivate it. And subsequent studies have shown that the antibody is internalized in the endolysosomal compartment and actually undergoes apoptosis, not apoptosis, but the IL-23 is cleared. So whether or not this has clinical importance is yet to be determined in terms of a drug like risankizumab, which you know is an IL-23 antagonist, does not have this property. So it'll be very interesting to see whether or not this binding to the FcR gamma R1 receptor has advantages that we're not seeing with other IL-23 blocking agents that don't have this property. So my major points are that treatment responses to a number of different agents in TNF inadequate responders is low, as I showed you, in part because this disease is very complex and heterogeneous and has a number of different domains, and as Laura pointed out, comorbidities that influence response. We know that the disease is comprised of multiple tissue domains driven by diverse mechanisms that heretofore are still poorly characterized. In the mechanistic model of PsA, disease is driven by inducers, IL-23, enhancers, IL-17, and effectors, TNF and PGE2, with specific immune stromal interactions in individual tissues, which we're still working on deciphering. CD8 T resident memory cells are critical effectors in both psoriasis and PsA, and tissue persistence may be maintained by IL-23. What I mean by that, actually not maintained, but may be limited and decreased by IL-23 blockade. And so understanding tissue-specific endotypes will foster a more precision-based treatment approach, and we are very actively, all of us on this particular webinar, working toward that end. And with that, I will thank you for your attention.
Thank you very much indeed, Christopher. A tour de force, and I think just impossible for us to overstate the importance of understanding the pathways that are driving the disease across the different tissue domains that we are treating in this really rather complex heterogeneous disorder. So thank you. And can I just remind our audience that we're looking for questions? You type them into the Q&A section online. I'd like there to be lots of really difficult questions for Christopher and for Philip and Laura. And as always, I'll pick up the easy questions. So if you can just get them typed in there as soon as you can, I'd hugely appreciate it. Now, we're going to move to our last formal presentation, which comes from Professor Philip Mease. Philip is going to take us into the clinical domain. He's going to think a little bit about how we can use this panoply of riches, and particularly understanding around the IL-23 pathway to treat across different tissue domains. Philip, over to you, sir.
Thanks very much, Iain. And thank you, Laura and Chris, for a wonderful introduction. And Chris, that was really, I agree, a tour de force on the looking at the molecular underpinnings of the disease. These are my disclosures. What I'll be touching down on are reviewing some of the data, including some post-hoc data on trials with guselkumab and psoriatic arthritis. Then I'll transition to talking about some, quote, real-world studies, which means long-term registry data, including the COREVITAS registry, and then some interesting work deriving data from the IQVIA insurance claims database. And then talking a little bit more and complementing what Chris had to say about the CD64 binding. We're using guselkumab as an example of an interleukin-23 inhibitor that binds specifically to the P19 subunit. There are two others, risankizumab, which has been approved for both psoriasis and psoriatic arthritis, and tildrakizumab, which has been approved for the treatment of psoriasis. There's also the slightly older medicine, ustekinumab, which binds to P40, so has a inhibiting effect on both interleukin-23, but also interleukin-12. The data with these drugs, especially the data that we have with risankizumab, is very similar to some of the data that I'm going to be presenting in relation to guselkumab, which we're going to be using as the key example. Let's focus on DISCOVER-2. This was the larger phase of 2 phase 3 trials that led to the approval of guselkumab in psoriatic arthritis. It was conducted in patients who were bio-naive and had evidence of active PsA and an elevated C-reactive protein. There were 3 arms to the study, including guselkumab 100 milligrams every 4 weeks, guselkumab 100 milligrams at week 0, 4, and then every 8 weeks thereafter, which is actually now the approved dose for the drug, versus placebo. And then we're going to be drilling down on some post-hoc analyses, which have to do with achievement of MDA and the individual elements of MDA, and looking at the efficacy of the drug across GRAPPA-defined disease domains. So let's start with the overall data on MDA. MDA is a outcome measure that has become quite popular both in clinical trials and long-term registries, as a target of treatment. This was originally developed in work done by Laura Coates, who was then a fellow working with Philip Hallowell in Leeds. This is prior to her move to become a professor at Oxford. The way in which she developed this particular instrument was by creating a number of hypothetical cases. I think there were 40 in all, and then asking clinicians who were expert in psoriatic arthritis management how they would define improvement or getting to a satisfactory place. And so here are the 7 items that constitute the MDA. Tender or swollen joint count less than or equal to 1. PsA score less than or equal to 1, and that would be done from clinical trials. We don't typically use PsA in the clinic, or what we do use in the clinic is an estimate of body surface area of less than 3%. Patient-reported pain of less than or equal to 15, patient global of less than or equal to 20, a HAQ score, a function measure, of less than or equal to 0.5, and a tender enthesial count of less than or equal to 1. For this particular project, Laura used the Leeds Enthesitis Index as the enthesial assessment tool. But in my experience, you can use practically anything, the Spark or whatever your local approach to measuring enthesitis, and just so long as there's less than or equal to 1, that you achieve that element. It's been shown that if you achieve 5 of these, which constitutes minimal disease activity, then you're in a great state. You have satisfaction with your treatment. You are functioning, you're working well in society, you're able to have better quality of life in general, your work productivity is good, and it's also correlated with lack of progression of structural damage. Notice now the data from DISCOVER-2. At week 24, a quarter of the patients in the trial had achieved this result. 33% by week 52 and 39% by week 100. You're going to see this over and over again with the IL-23 class, that even though there are really excellent results at the primary endpoint of week 24, there's better yet to come. And so when you look over long-term analyses, including non-responder imputation analyses out through, say, week 100, you get really good results. Primary endpoint of ACR20, for example, goes from 64% up to about 75% out at week 100. So there's a sustained persistence of effectiveness and even climbing effectiveness over time. This is now an interesting analysis where we're breaking down the individual items that constitute the MDA. And notice what responds the quickest, getting to that low threshold that we're trying, that threshold of improvement that we're trying to get to. The objective measures, the skin score, the PsA score, the swollen joint count, and the enthesitis measure. Intermediate in time is the tender joint count. So we're introducing an element of subjectivity on the part of the patient. And then at the top of this Kaplan-Meier type curve, we're seeing the patient-related items of pain, patient global, and that's what is the slowest to respond. So there are many elements that go into that particular patient aspect of assessment, including sometimes non-biologic items like depression and anxiety. Here we're looking at a bar graph which shows similar kind of data, but in graphic and numeric form. So showing that the patients had highly significant 68% improvement of the PsA score, and then also of the Leeds Enthesitis Index in purple, swollen joint count in blue, tender joint count in the darker blue. And see the same phenomenon of more response over time. Now we're looking at other measures, including achievement of what's called DAPSA low disease activity in nearly 60% of patients, and PASI 90 and 70% at week 100. This is using the approved dose. Complete enthesitis resolution using the Leeds Enthesitis Index in 70% of patients, and dactylitis resolution in 83%. These are very solid results. Now, one of the strong suits of the IL-23 inhibitor class is safety. And here is noted the fact that we don't see a signal for malignancy. There's very little in the way of serious infection. We don't see a signal for MACE, major adverse cardiovascular events. We don't see laboratory abnormalities of concern. And so that is one of the things that it's very easy and straightforward to talk to patients about and can be reassuring about overall safety. There's some trials that are underway with guselkumab, which I think are going to provide us with some very important answers to questions that we have. One of the questions was alluded to by both Laura and Chris earlier, and that is that many of the patients that we're seeing in clinic each week are ones that we would consider difficult to treat. They've failed or had inadequate response to multiple different medications. And so we're wondering, what can we do? Can we intensify the dosage of the single immunomodulatory medicine we're using? Or more like oncologists who tend to treat cancer with multiple different medications at the same time to really hit cancer hard and get rid of it. We should be doing some of the same in rheumatology. So here's the Affinity trial. This was a pattern after a previously published trial known as the Vega trial with guselkumab, in which they were looking at ulcerative colitis improvement with the combination of guselkumab, an IL-23 inhibitor, along with golimumab, a TNF inhibitor, and versus golimumab or guselkumab alone. And in that Vega trial, demonstrated that the combination not only was better than either therapy as monotherapy, but also had synergistic effects in terms of improving pro-inflammatory gene expression, looking at colon biopsies. So modeled after that, the Affinity trial is looking at patients who've failed at least one TNF inhibitor and are then receiving either guselkumab monotherapy or a combination of guselkumab and golimumab. And we're very excited to hear the results of this study soon so that we can understand whether there is actually benefit to using two biologics together and turn to regulatory agencies, pharmaceutical companies, and payers to convince them that to study this particular approach and determine its relative safety and efficacy is important for our patients that are finding it difficult to treat. The second study mentioned here is the STAR study. This is to address the question, how well does guselkumab work in the axial component of psoriatic arthritis? Laura outlined this particular point well earlier, that there may be some differences between axial psoriatic arthritis and axial spondyloarthritis, where in one phase 2 trial with risankizumab, it was shown that there was not a benefit in axial spondyloarthritis that is radiographically defined. And so, but there was interesting data from the Discover 1 and 2 trials where we did post-hoc analysis and found that patients who had an axial component defined as having that by the investigator, but also having sacroiliac abnormalities consistent with sacroiliitis, that they could benefit from guselkumab. So this is a study in MRI-confirmed axial PsA to determine whether that is truly the case and how effective can it be. And then the APEX study is mentioned here, looking at the question of, and more deeply about inhibition of structural damage as measured by X-rays in patients with psoriatic arthritis. Let's turn now to some real-world study data, and I'm going to go through a couple of slides on the CorEvitas registry looking at 6-month data, and then an interesting analysis on persistence of use of guselkumab versus IL-17A agents or TNF inhibitors from the IQVIA database. Here we're showing from the CorEvitas registry the proportion of patients that were started on guselkumab who had various outcomes, including CDAPS, so low disease activity remission, CDAI, low disease activity remission, body surface area achievement of less than 3%, investigator global assessment of 0 clear or almost clear, and also a investigator global of completely clear, as well as MDA, VLDA, very low disease activity achievement. And as you can see, all of these are mirroring what we just saw with the data from the clinical trials. So this is real-world data evidence in a clinical registry that supports the type of benefit that we saw with trials. Drilling down to patient-reported outcomes, these are important thresholds for improvement of pain as a reduction of at least 30%, which is considered important, and reduction of at least 50%, which is considered a major improvement of pain. And then reduction of at least 10, which is considered MCID. So clearly there's improvement of pain, and on the right-hand side, improvement of patient global and fatigue. And then lastly, here we have from the IQVIA database where there was propensity matching scoring between patients who were on guselkumab or on IL-17A inhibitor on the left-hand graph or TNF inhibitor on the right-hand graph. And what is shown is that there was greater persistence with the IL-23 inhibitor guselkumab. A twofold increase in terms of IL-17A and threefold increase compared to TNF inhibitor. This is important to us because of the phenomenon that we often see of patients having inadequate response and losing response over time. Here's a single slide which reiterates and supports the point that Chris Ritchlin made earlier about this unique ability for guselkumab to bind directly to CD64 myeloid cells, and in so doing, be able to sort of capture at the source of IL-23 generation from these cells that are often tissue-resident memory cells, the ability to bind to IL-23 directly at the cellular source. We have yet to know whether this has real clinical significance, but it is an interesting differentiation for this particular molecule. So in conclusion, we've walked through key phase 3 trial, Discover-2 in bio-naive population that showed not only key benefit at the primary endpoint of week 24, but even climbing benefit as we look at NRI data out through week 100. We saw from real-world evidence databases a similar kind of effectiveness in various outcomes that are reported in these long-term registries, as well as persistence of effectiveness over time compared to other mechanisms. So we look forward to further both translational as well as clinical studies to further confirm all of these observations. So thank you very much, and let's turn it back over to Iain to guide us through the next section of our presentation.
Thank you very much indeed, Philip. Thank you, Christopher, and thank you, Laura, who, as if by magic, instead of virtual Laura, we have real Laura. And you can't tell the difference. Who knew? Laura, it's just lovely to have you joining us. And what a splendid selection of talks we've had to listen to tonight. So we've got some questions online. I've tried to make some of them visible to you, others not. But feel free to put some more questions into the chat website, and we'll be happy to pick as many of them up as we can. We have kept a few minutes aside for questions, and I'm going to actually start with mechanism, and we'll go from there into clinic, just to get Laura time to get her breath back there. So, Christopher, you have attracted quite a lot of interest in these resident memory T cells. Now, there are some clearly very, very wise minds on the call today, because they've asked some very, very astute questions. So, first of all, and actually, if I can take two of the questions together, from Pageman and from Thomas, which are kind of asking the question is, could we go after TRMs themselves if they're absolutely pivotal? Or could we start to think about going after distinct subsets of, be they T cells, innate lymphoid cells? The examples that Thomas gives us would be just target the Th17 cell, the TRM1, or a gamma delta T cell. So your thoughts on specifically going after the resident memory T cell compartment, or even the broader, those cells producing 17A? Thanks.
Yeah, it's a fascinating cell that I didn't have a chance to go into too much depth, but it's important to point out that these can be of CD4 and CD8 type of cells, and that they express alpha beta receptors. So the idea that I would think of as much as been thinking about in AXSpA with a TRBV9, which is a specific T cell receptor that might be important in axial SpA, would be that you'd really want to focus on T resident memory cells with specific alpha beta receptors that are pathogenic. So that would be the approach I want to take. I think if you do too broad a T resident memory cell approach, then you're going to open up the possibility of pathogens, because that's what they're not only there to cause autoimmune disease, they're there to protect us against pathogens. And so I think as directed approaches you could make would be the approach that I would be thinking about moving forward. In fact, we're talking about this. This is something we think is an important area to pursue.
Yeah, thank you.
Could I just add a comment?
Yeah, please do.
So we've had Chris was. It's interesting you brought up the TRBV9 story there. We saw not too long ago a single case report from Russia of a patient who was treated with a monoclonal antibody to that particular signature on their 4% of their lymphocyte population. But then there was that was followed. Then there was a lot of question: do we trust this data or not, coming from a single patient? But then that was followed with a phase 2A level trial in 120 patients, and it appeared to be successful. And I've heard murmurings about not only having a monoclonal antibody, but having a T cell engager directed at TRBV9. What is some of your thought about that?
Well, I think that these are strategies we're talking about, and there's a number of startup companies that are trying to develop not only the BiTE therapy you saw. There was an important trial in RA that we covered, Philip, you remember. Yes. I think that my own specific approach, and I'd like to hear what Iain has to say about this, will be really trying to direct it to the alpha beta receptor that is oligoclonal and may be very important in pathogenesis. I think BiTE is more challenging in SpA and psoriatic arthritis, because at least at this point in time, we don't know that B cells are the critical cells, and we don't think so, but there may be. We know that you can see lymphoid aggregates in some PsA synovia, but I think we'd have to use a BiTE therapy that's directed toward a different target, which is certainly possible. So I don't know, Iain, what do you think?
Yeah, fascinating. I'll give you my hierarchy of thoughts. First of all, I would only go after, well, first of all, to deplete TRMs as a class feels to me like we're going to run into vulnerability in terms of host defense.
Yeah.
So I actually like it as a thought experiment, but as a clinician, I would balk a little at it.
Agreed.
But then coming into going after specific T cell clones, that's very interesting. Actually, if you go back in ancient history, people have always surmised that psoriasis flare might be driven by superantigens. Remember those stories, infection-driven psoriasis flare by superantigen-driven T cell activation. So all the time, that is it's an interesting thought, but I've never been persuaded that the T cell compartment, as at the clonal level, if you like, was the right target unless you could bring about a depletion event or a neutralization or tolerizing event on that T cell compartment, number one. And number two, that brought about durable response, equivalent to retolerizing or immunologic reset. Now, of course, we're having that conversation in the CAR T, CD19 and CD whatever else literature, which is very interesting. We're not going there today because we've got more than enough exciting stuff to talk about. And I think, Chris, until I'm persuaded that I know exactly which T cell subset I need to take out and that I can give myself durable response, then I would, as you wonderful American friends call it, a rain check. I don't know why you do that, because I've already made the point that it doesn't seem to rain in Seattle. I mean, we need rain checks here in Glasgow. We need umbrellas and rain checks. Anyway, the final thing I'd like to say, to kind of circle back to the topic today, particularly IL-23, IL-17 axis. IL-23 and IL-17A, and in fact, for that matter, 17AF, and I think you demonstrated this beautifully, Christopher, they're different kinds of cytokines. There's upstream regulators, that's the IL-23 pathway, and there's downstream effector cytokines, like, for example, 17A, 17F, TNF, and others. And I wonder if actually our questions are very elegant, because at one level, the questioner is really saying, can we go after the regulator? Can we take out that regulatory cell and that regulated cell type? Or do we just stick to downstream inflammatory suppression? Right. And honestly, when you look at the moment, we don't have the good head-to-head clinical data. We really love to know what happens when P19 comes up against, I don't know, dual 17AF inhibitor. There's some data in the cutaneous literature which are quite interesting, but we're going to be rheumatological today and avoid that particular bear trap. So those are my thoughts for what they're worth. A very elegant question, I have to say. I'm quite keen to bring we might come back to a little bit of cytokinology, because who doesn't love cytokinology? But as we have Laura with us, I want to actually go right back to an earlier part of your discussion, Laura. I was intrigued by the concept of difficult to treat. And I was intrigued by the concept of complex to manage. Let me tell you, in a multi-morbid, rich environment like Glasgow, pretty much everyone would be C2M. And I'm a bit worried about that as a discriminatory definition. So I'm going to leave that aside. And I'm more than happy to have a discussion with the luminaries of GRAPPA who will put me right in my ways. But D2T is very, very interesting. So I wonder if you could think out loud about D2T and whether you consider that a clinical diagnosis defined by number of drugs failed, which is what we did in EULAR when we thought about rheumatoid, if you recall, amongst other things, by the way, or whether difficult to treat really is it a biologic state. And maybe we can circle back, Chris, just to give you the heads up to some of the thoughts you've given us. But Laura, just that clinical concept, please, a little more would be fascinating.
Yeah, so I think this is a group of patients that obviously cause us a lot of concern in clinic. This is the patients that we struggle to get under control. And I think historically it's been a group of patients that a lot of drug trials have excluded. So having a definition from EULAR or from GRAPPA around these patients and a focus on these patients is important, because they're a small proportion of our population, but a big proportion of our workload, trying to get these patients well. I like this distinction between difficult to treat and complex to manage. I don't think anybody's particularly simple to manage. We're all complex creatures as humans at the end of the day. But I think it brings in the idea that we're not just inflammationologists, that we are looking after the person as a whole. And that in some patients, we can control inflammation, but maybe not get them to the normal life that we would aspire to. And in some patients, we can't even control that inflammation kind of as a first step. So I think having that distinction is useful. Although I agree, it covers a large proportion of our clinical population who are complex to manage because they have comorbidities and other things going on.
Cool. Well, you've wandered into one of my favorite topics, but as I promised that Christopher was going to just think out loud with us about the pathogenesis of difficult to treat disease. And then, Laura, I'm going to come back to that issue of what's going on in the other tissues. I think that's fascinating because Stacey online has also asked us a question about that. So I'm going to weave those together. But Christopher, just a thought, if you wouldn't mind, about pathogenesis-driven resistance to treatment or
yeah, I like you, Ian. My clinic is a complex to manage clinic. I mean, it's an incredibly, and I think Laura beautifully outlined the importance of the comorbidities. And we find that in our patients who are difficult to treat, in particular, the comorbidities loom large, and trying to control that is our major focus right now in terms of diet, in terms of exercise, and trying to deal with the control of diabetes, hypertension, all other things. So very important. So in terms of what do we think about this from a cytokine perspective? Well, this is something we're studying intensely. You are too in Hippocrates, both of you. We're using humanized mouse models and also using tissue analysis of synovium and skin. One of the things I'm thinking about is the interferon axis may be more important than we think in the patients that are not reaching the responses we'd like to. And there's a lot of data supporting that, although still it needs a lot more support. So I think that's one element of it. And the other element is the notion that we can control disease well with one cytokine blockade, I think is passe. I don't think we can. And then thirdly, most important, and you and I, Ian, are totally on board with this, is the different signatures of the domains and how we can specifically address those in individual patients. And I think that's going to be critical to us achieving long-term, sustained, deep outcomes.
Yeah, thanks, Christopher. Yeah, and just to that, my favorite abbreviation of the year that I've come up with, hypoxia-induced in airplane, was treat tissue to target, T squared 2T. So that's my contribution to GRAPPA this year. So listen, I promised Stacey that we just pick up. She's asked a great question, which is there any evidence or suggestion of upregulation of IL-23 in obese metabolic patients? And the answer, Stacey, is you're spot on. There absolutely is. Not only that, but in some cancer models, they actually look as if they may be functionally related to what happens in cancer models. If you lose weight, adipocytokines, but also IL-23 levels come down. So that's all very interesting. And perhaps you're also alluding to the work that several of us were involved in demonstrating in a randomized Mendelian analysis that obesity is causally related to the psoriatic disease spectrum. So I think you're onto something there. And of course, that makes IL-23 a really very interesting regulatory molecule. For sure. Philip, you've been ever so patient. I'd like to just come back to you because we're beginning to move towards the top of the clock and the bottom of the hour. I think that's what the commentators all say in American football anyway. So I was trying to be relevant to my North American friends here. Philip, you talked about the comparison of trial data and real world evidence. And Laura alluded to the fact that a lot of people in the real world don't get into trials. So those real world evidences, I think, are really, really important, and they're a very helpful insight for us this afternoon, this morning, this evening. And could you maybe just expand a little on that for us, please?
So you point out the key, one of the key differences, and that is that we really cherry pick the patients that go into clinical trials based on all the inclusion and exclusion criteria. So the patient can't have a major other medical illness. major diabetes. There's some restrictions on potentially in some trials on body weight. There are potential restrictions on if you have major depression. What real-world evidence does in clinical registries is it allows us to look at the full spectrum of the human experience and gives us a more realistic picture of what drug response might be. And so if you see a correlation or similarity in the real-world evidence as compared to clinical trial data, then that's reassuring. Yeah. It tells us that yes, when we go in and talk to a patient about the percentage responding from a journal article, that we can back that up by saying, and this has also been shown in registries. And it can give us some important clues about safety that we may not pick up in a clinical trial because there are many larger number of patients in registries, and that's important for us to see if there's some rare but important safety issues that may arise. So I'm a great a strong proponent of looking in clinical registries over time. Yeah, one of the things, too, that we're going to be learning with registries as well as clinical trials is this whole issue of what happens when we really concertedly lose weight, or our patients do, not only from dietary and exercise approaches, but now that we have this new group of weight loss drugs that are highly effective at weight loss and are also turning out to have some immune regulating properties. We may start finding that we're using dual therapy, not only with two different immunomodulatory biologics, but also combining with weight loss drugs.
Yeah, I absolutely. And just that brings really to the fore this concept of treating tissues to target. Anyone would think we talk to each other, Professor Mease. There's one final area I want to come to, and actually just warm thanks to Evan Leibovitz online. A couple of great questions. One of them I think I've hopefully been able to show this is there a role for fibroblasts in tissue? Let me deal with that really quickly. The answer is almost certainly yes. A lot of single cell and spatial biology data. Stefano Alabernini, Mariola, my group, Christopher, others. So I think the fibroblasts are metabolically and immunologically active in the psoriatic skin and enthesis and synovium. What is a bit less clear is how we target them. So far, targeting fibroblasts has been a touch tricky. So that's a watch this space. And as to whether that would offer selective advantage around pain and fatigue, I'd refer you to the work of Neil Basu and his colleagues looking at immune-mediated central pain sensitization, fatigue, and also Philip has written extensively in this area. So I think that we don't have a fibroblast. I think it's more likely to be microglial cytokine neuronal interactions. But the last one, and this is going to be such a challenge to such a talented group of speakers. We have 2 minutes, lady and gentlemen, to answer the other question, which is, what about the old thorny issue of IL-23 in axial psoriatic arthritis? So, Laura, you've got 30 seconds, and then I'm going to give you 30 seconds each on that, and I'm going to be meticulous. Laura first.
Negative trial in AXPAR. Positive data on BASDI in peripheral PsA, which isn't enough because the outcome measures are too woolly and non-specific. So we need a proper study to look at it, and at least there's going to be one. I'm not convinced that it's different enough that it will be effective, but we'll see.
So analogous to maximize with IL-17A inhibition. Christopher, over to you. Your 30 seconds start now.
Yeah, no, I agree with Laura. I think that we were all shocked by the results of the AXPA data years ago, and we've tried to find explanations. We all have our own theories and hypotheses, but it really is going to take a really carefully designed clinical trial, which is underway, to answer the question.
Thank you. Philip, the last word, sir.
I agree.
I love a man who uses 2 words but is so succinct. Ladies and gentlemen, let's bring our webinar to a close this morning, this afternoon, this evening, wherever you are. Look, it's been a tour de force. We've thought about clinical heterogeneity. We thought about the kind of pathways that we're starting to unravel as we look to capitalize on those unravelings for therapeutic benefit. And then Philip has taken us through the clinical implications of that, with particular emphasis on the biology and clinical value of IL-23, P19 as a target. Just thinking about the various medicines available to us to go after that target now, and with the potential prospect in future that subtle variations in the way in which we do that may have clinical benefits. Watch this space. I've learned a huge amount. I hope you have too. Please send us some feedback. Let us know what you thought. Thank you so much for giving us your time. We hope you've enjoyed this in real time, or if you're listening in retrospect, I hope you've found it educational. Fill in the evaluation form. Let us know what you thought. The live streamlined version of this will be available on the IMED Forum YouTube channel soon. My kids are thrilled that I can say I'm on YouTube television. They sometimes they even ask me for my autograph, and I give it to them. I'm nice that way. But please have a look at it online, and as always, you can get this on demand at any time over the IMED Forum. Thank you so much to our sponsor, J&J. They've allowed us to offer what I can assure you are the opinions of the faculty, and I hope that that's been interesting and helpful to you. Final thought, there's upcoming podcasts. You recognize these characters, and if you don't, you've been asleep for the last 90 minutes. Professor Christopher, Professor Philip are going to be giving a summary podcast that will highlight the key messages from this webinar. So with that, ladies and gentlemen, wherever you are in time, wherever you are in space, I hope you've thoroughly enjoyed this. We wouldn't do this if you didn't come along to listen. And thank you, by the way, for the questions, really insightful. And to my fellow faculty, very, very warm words of thanks. And of course, to the IMED Forum, thank you for letting us reach out to the people who really matter, the clinicians looking after our patients. Thank you. Good morning, good afternoon, good night.